So welcome guys. In today's session, we'll be discussing about aortic dissection. And aortic dissection, we first have an introduction, look at the pathogenesis, morphology, classify, then look at the clinical features. That's easy. Welcome all, my name is Wallace Munyeri, and I'm the Daktari. So aortic dissection, what is aortic dissection? Simply refers to when blood separates the laminar planes of the aortic media to form a blood-filled channel within the aortic wall. Okay, so here you have the aortic wall, that is the tunica intima, media, and adventitia. Then you can see here the blood in the lumen tears the intima. Then once it tears the intima, it separates the laminar planes of the aortic media to form a blood-filled channel within now the aortic wall. Now that is dissection. Okay, and okay. Now note this: an aortic dissection does not need to be associated with an aortic dilation or an aneurysm. So the older term dissecting aneurysm is avoided. Okay, so you can have a dissection with no dilation. So that is why the word dissecting aneurysm has been dropped. And now the aortic dissection is the one in use. Now, let's move forward. This aortic dissection occurs in the following scenarios or in the following groups of people: men aged between 40 to 60 and who have an antecedent hypertension. And in that case, 90% of the dissections will occur in this group. Also, in younger patients who have connective tissue abnormalities, such as Marfan syndrome. I told you Marfan syndrome is due to mutation of the fibrillin gene located in chromosome number 15. So when fibrillin is mutated, the elastic tissues will be will be dysfunctional, and so the sequestration of transforming growth factor beta won't be there. So there'll be increased amount of transforming growth factor beta, and you know transforming growth factor beta is involved in the smooth muscle proliferation. Now, also they can be iatrogenic, okay, such as during catheterization or cardiopulmonary bypass. You can during those procedures there can be an intimal tear, and this will complicate the arterial cannulations. Also, pregnancy is associated with dissections, but rarely, just in 10 to 20 cases per million births. And typically it occurs during the third trimester, and this is related to hormone-induced vascular remodeling and the hemodynamic stress of the perinatal period. Okay. Also, dissection, note this, that dissection is unusual in the presence of substantial atherosclerosis or other causes of medial scarring. Why? When there is atherosclerosis or medial scarring, there won't be the separation of the laminar planes of the aortic media. So this will inhibit the propagation of the dissecting hematoma. Okay, so atherosclerosis and medial scarring will limit the propagation of the dissection. Now, let's move forward and look at the pathogenesis. Now, the pathogenesis is mainly due to weakened aortic media. And what can weaken the aortic media? Hypertension. Hypertension. Note that hypertension is the major risk factor for aortic dissection. Why? During hypertension, one, the vasa vasorum will undergo stenosis. There will be luminal occlusion, okay, due to arteriosclerosis. Okay, so when you have that, the aortic media will become attenuated, and hypertension, I told you, accounts for 90% of cases of dissecting. In fact, this should need to be dissecting aneurysm, should be aortic dissection. I told you the word dissecting aneurysm has dropped. I don't know why I didn't drop it here, so I should also drop it here. Okay, and Also, non-hypertensive cases include Marfan syndrome, where you have cystic medial degeneration, which simply refers to a fragmentation of the elastic fibers with the loss of smooth muscles. Also, iatrogenic trauma, okay, and also pregnancy, especially in the third trimester, but this occurs in 10-20 cases per million births, so it is relatively rare. Let's look at morphology. Now, note this. In most dissection, the intimal tear, which marks the point of origin of the dissection, is found in the ascending aorta in most cases, and just 10 centimeters above the aortic valve. Okay. Now, those tears are usually transverse or oblique in orientation, and they measure 1 to 5 centimeters long, and their edges are sharp and jagged. Okay. Now, the dissection plane may extend retrograde, so it might extend now towards the heart, okay, or it might extend anterograde or distally to as far as the iliac or femoral arteries. I'll be showing you that. And in most cases, this dissection lies between the middle and the outer thirds of the aortic media. Note that is a very important point. Now, external rupture. Imagine now you have blood within the aortic media. Now imagine now if the tunica adventitia ruptures, there will be a massive hemorrhage, okay? Or if it now ruptures within the pericardial sac, there will be a cardiac tamponade, and this might lead to heart failure. Now, the dissecting hematoma can re-enter the lumen of the aorta through a second distal intimal tear. So imagine, let me try to draw that. Okay, now imagine this is the aorta, this is the lumen, and now these are the aortic walls. Okay, now imagine if you had a first tear here, then blood dissected, then another tear. So you will have now 2 channels within the same blood vessel. So it will there will be a second vascular channel, and this will create the so-called double-barreled aorta. Okay, and over time, this first channel may become endothelialized. It might acquire an endothelial lining, and especially in cases of chronic dissection. Now, the most frequent histologically detectable lesion is cystic medial degeneration. Okay, and it is characterized by smooth muscle cell loss and necrosis, elastic tissue fragmentation, and we also have accumulation of amorphous proteoglycan-rich extracellular matrix. Okay, so but that does not mean that medial degeneration is a prerequisite for aortic dissection, nor does it serve as a marker of increased risk of dissection. Okay, so you might find in some patients their media is fine, but they have a dissection. In others, you might find in especially autopsy cases, there is severe medial degeneration, but they don't have a dissection. So it is not a prerequisite for a dissection. Okay, so let's now look at that. Okay, here you can see this is the heart. This is the proximal aorta. It has been cut and open. And here you can see this is the intimal tear. Okay, this is the intimal tear. Then I want you to note something. This area is atherosclerotic, and then you can see the edges of the dissecting hematoma there. This atherosclerosis is like limiting the spread of the hematoma. So remember I told you in the setting of atherosclerosis or medial scarring, dissection is rare because that will limit the dissecting hematoma. Okay. Then here you can see this is the, from here to somewhere here, this is the aortic media. Then you can see something peculiar here. This is blood within the the aortic media. So that is a dissection there, aortic dissection. Now, here you can see now when I told you about the double-barreled aorta, you can see this is a double-barreled shotgun. Okay, so that is how the aorta will look like. And in this case, they look like this. There will be a true lumen, now the original one, and the false lumen. Okay, now the true lumen is round or oval, and it has strong systolic Doppler velocity, and thrombus rarely occur here. Okay, but in the false lumen, it is crescentic shape. The velocity is slow, sluggish, or no Doppler velocity. Thrombus are common. Why? Because there is stasis. Also, there are cobweb formations. Okay, so those are the differences between now the true lumen and the false lumen in the double-barreled aorta. Okay, now classification. These dissections are classified using two classification schemes, STANFORD or DEBAKEY. Okay, now STANFORD classification. Under STANFORD, it can be either type A or type B, depending on where the lesion is. Now, if the tear occurs in the ascending portion of the, if it occurs in the ascending portion of the aorta, the ascending aorta, or within the arch of the aorta, that will be type A. Okay, and it is the most common and more dangerous. Okay, now if it occurs, if the intimal tear is at is distal to the subclavian artery, the left subclavian artery to be specific, that would be type B according to STANFORD classification. Okay, and type A, it can involve the descending portion of the aorta, so it can be with or without. Now, under now type A, let's see how now DEBAKEY classified them. Now, it classified into three types: type 1, 2, and 3. Now, type 1 originates in the ascending aorta, then it propagates at least to the aortic arch and often beyond it distally. So the intimal tear in type A will be in the ascending aorta. Then the dissection will propagate through the aortic arch and distal to it. Okay. Then in type 2, the intimal tear is in the ascending aorta, but the dissection is confined to the ascending aorta and then the arch of the aorta. Okay. In type 3, the intimal tear will lie distal to the left subclavian artery, and the dissection will extend distally down the aorta. Okay, rarely retrograde into the aortic arch and the ascending aorta. So this is what I'm saying. Now, under STANFORD, this is type A. You can see the intimal tear here is confined to the ascending aorta in type A, STANFORD, under STANFORD classification. In type B, you can see the intimal tear here is distal to the left subclavian artery. Okay, then under the DEBAKEY, type 1, you can see the dissection is extending distally. So the tear is there, but it is extending beyond the arch of the aorta. But in type B, DEBAKEY 2, the second type, the dissection is confined to the ascending aorta. Then in DEBAKEY type 3, the dissection, the intimal tear will lie distal to the left subclavian artery. Then the dissection extends distally. So there we are. So that is how you classify them. Now, clinical features. That's the last thing. Then, so the patient will present with a sudden onset of excruciating, tearing, or stabbing pain, which will begin in the anterior chest. Then it will radiate to the back between the scapulae, and then it will move downward as the dissection progresses. Now, in this case, the most common cause of death would be a rupture of the dissection into the pericardial, peritoneal, and the pleural or the pleural cavity. Okay. Now, retrograde dissection, especially in the type A under type A STANFORD classification, might extend to the aortic root, and this will cause a fatal disruption of the aortic valvular apparatus. And also, and due to that, it will lead to aortic insufficiency, and it can compress the coronary arteries, leading to a myocardial infarction. And what about if it ruptures within the pericardial sac? A cardiac tamponade will ensue. Now, other complications are related to the extension of the dissection to the great arteries of the neck, and the renal, mesenteric, or iliac arteries may be seen. And now imagine if you have an obstruction of like say mesenteric artery. Okay, so you can imagine the catastrophic events which might follow that. Also, you might have compression of the spinal artery, such as the artery of Adam-Quays, and this will lead to transverse myelitis. Okay, I think that was that. Very easy. And thank you for your attention, guys, and follow for more med content. Thank you very much.